All right. Um, so a checklist for pelvis and perineum. First thing is when you go back to the bony anatomy, you divide your pelvis into a false pelvis and a true pelvis, being separated by the pelvic brim in this region, and which somehow coincides with the pelvic inlet. So boundaries for the pelvic brim, um, or your pelvic inlet. Anteriorly, there is the symphysis pubis, which basically is the cartilaginous joint between your two pubic bones. Laterally, you have these iliopectineal lines. Right? Then posteriorly, I have the sacral promontory, which so happens to be more indented in the male compared to the female. Right? And that's what gives the pelvic inlet the shape, where in females we say it's oval, then in males we say it's android shaped. Right? Then the boundaries for the false pelvis, laterally you have the iliac fossa in these regions, where there is origin for the iliacus muscle. Then posteriorly there will be the lower lumbar vertebra. Anteriorly you expect to have the lower anterior abdominal wall. And what you may need to remember about the false pelvis is the fact that um, it does have a function in early labor and in guiding the the fetal head. Right. Then the true pelvis is the space between the inlet and the outlet inferiorly. And the outlet, in terms of the boundaries, you have the pubic arc anteriorly. On the sides, you have ischial tuberosities, which said I can project from this picture. Then on the back, you have the coccyx. Posterolateral, you also expect what's between the vertebral column and the ischial tuberosities, which is the sacrotuberous ligament. They also form boundaries of they also form boundaries of your pelvic outlets. The true pelvis houses most of the pelvic organs, and it's separated from the perineum below by the pelvic diaphragm, which brings us now to the walls of the pelvis. The pelvic diaphragm forms the floor, and it's made up of levator ani as well as um, the coccygeus. Right. Then the lateral pelvic walls, there's the obturator internus and the adjoining part of the hip bone on the inside. The posterior pelvic wall, there is the muscle called piriformis and the adjoining bones there, which happens to be the sacrum and the coccyx. By now, you should be able to appreciate that both the sacrum and the coccyx, they consist of fused vertebra, which are wedge shaped. So they have an appearance like this. The base is up, the apex is below, right? Then clinicals, Robert's pelvis, absence of ala of the sacrum, total absence. Nagel's pelvis, this is where you have partial absence of the ala. Then you can talk about assimilation pelvis, which can be high assimilation or low assimilation. In high assimilation, you have displacement of the joint superiorly. So sacroiliac joint, instead of being a joint between the ilium and S1, it's displaced superiorly to the lumbar vertebra. That's high assimilation. Then low assimilation is displaced inferiorly, for example, to S2, S3. Right. Then rachitic pelvis is a pelvis that has assumed a bed shape as a result of um, acquiring rickets before, and there's bone softening, then the pelvis actually contracts inward. Right. Okay. Then I won't dwell much on this, but you also need to appreciate the differences between the male pelvis and the female pelvis. And one of those differences has to do with the pelvic inlet, where we say in males, for example, this specimen there, the inlet is android or heart shaped. Then in females, it's oval in shape. You also need to be able to distinguish the four types of pelvis, and be able to know which one is broad shoulders, which one is what, which one is more inclined to a proper normal delivery, which one does not support delivery. For example, platypelvic pelvis, it's an indication for a C-section, because you can then support a normal vaginal delivery with that. Then since the checklist, the pelvic diaphragm, you said it's on the floor, and remember, it's actually going to have openings. For females more, there's a urogenital hiatus, as well as the opening for the anal canal there, where it becomes continuous with the rectum. Right. Then the rectum, what you need to know, firstly, is a peritoneum issue, where you say the upper third of the rectum is covered with peritoneum on its anterior surface and the sides. The middle third is covered only on its anterior surface. Then the lower third is devoid of peritoneum. You need to remember that. Right. Then 13 centimeters in length. I'm not gonna waste your time saying that. Rectum is sensitive to stretch only, because it's innervated by inferior hypogastric plexus only. And in terms of its relations, I've always used to give an analogy where you say rectum, uterus, bladder. That is from the back going anteriorly. And this is for females. For males, you just remove the uterus there, meaning in front of the rectum actually lies the bladder, which is why you can approach the prostate from the rectum, because the prostate is just below the bladder. When you want to do a prostate examination, you just put your glove fingers through the rectum, then you go anterior. Right. Then I also want you to know this ischiorectal fossa, and remember the boundaries of the ischiorectal fossa. The medial boundary is made up of the sloping part of the levator ani. Right. Then the lateral boundary is made up of the obturator internus. This ischiorectal fossa is filled with fat, and the content of the ischiorectal fossa, we have the pudendal canal on the lateral wall, this one. And within your pudendal canal, you expect to have pudendal vessels and nerves. So there are the internal pudendal artery, internal pudendal vein. There's also the pudendal nerve. And strikingly, within that same pudendal canal, also called Alcock's canal, you have the inferior rectal vessels and nerves being given off. They're given off in that fossa, and they cross the ischiorectal canal or ischiorectal fossa. Right. The newer editions of the books, they say ischioanal fossa, almost the same thing, right? Then an infection from one ischiorectal fossa can spread to the other ischiorectal fossa through a posterior horseshoe-shaped recess, meaning there is a recess that goes behind the anal canal that allows for communication between the two ischiorectal fossas. So infection in one can actually spread to the other through that recess. It does not spread through the other two recesses, which we call anterior and posterior recess. Right? It is through the posterior horseshoe-shaped one. Right? Okay. Then for the bladder, I want you to know shape. Empty bladder versus a full bladder. Empty bladder being almost pyramidal in shape. Then a full bladder is conical in shape. Right. Then also remember that in children, due to the small pelvic cavity, the bladder in children is going to be an abdominal pelvic organ. Whether empty or full, it lies in both the abdomen and the pelvis. Then in adults, the bladder is entirely a pelvic organ, but when full, it peels off the peritoneum on the anterior abdominal wall and rises into the abdomen, which is why if you see someone who's holding back their urine, they tend to have a distended abdomen. Then the bladder is an apex. The apex of the bladder is where the remnant of the allantois is found, which for the purpose of this video, we'll call the median umbilical ligament, also called the urachus, which connects the apex of the bladder to the umbilicus. Right? Then the bladder rests on its neck, and histologically, remember the neck of the bladder is where we start seeing the three layers of the detrusor muscles. Right? So females don't have a prostate. So the next big thing is to say that the male prostate, the base of the prostate is in contact with the bladder. The apex of the prostate is in contact with another diaphragm that we call the urogenital diaphragm. Urogenital diaphragm is made from sphincter urethrae and the deep transverse perineal muscles. Right. So since in females we don't have this prostate, the neck of the bladder will rest directly on the urogenital diaphragm. Right. Then your bladder will also have a trigone at the back. The trigone embryologically is the only one that comes from intermediate mesoderm. The rest of the bladder is endodermal in origin. It's going to originate from endoderm of the hindgut, which basically forms the cloaca. Then the cloaca will partition. You know that story, right? Then the trigone is bounded on top by the openings for your ureteric openings, rather the ureteric orifices there. So we have an interureteric ridge. Right. Then we have the urethra below to bound your triangle. Right. Then on the posterior surface of the bladder, that's where you expect to see. I think this is a clear picture of what I'm trying to say. And the trigone is smooth. Unlike the rest of the bladder, which is folded, where you have those rugae, so when you describe the histology, your trigone is actually smooth. Right. On the posterior surface of the bladder, we have the two vas deferens separating your seminal vesicles. And remember, the two vas deferens, they end by dilating to form the ampulla of the vas deferens, which is then drained by a duct. The duct of that ampulla would then join the duct of the seminal vesicle to create the ejaculatory duct. Then blood supply for the bladder is superior vesicle and inferior vesicle, which I'm sure you know. The blood supply in the pelvis is from internal iliac. Then lymph drainage. Bladder is one of those few organs which do not really follow the concept of saying if blood supply is coming from Y, lymph will follow lymph vessels that are associated with Y. So yes, some of the lymph for the bladder will go to internal iliac nodes, but most of the lymph in the bladder will actually go to external iliac nodes. Right. Then you also need to know the prostate. Prostate, we will say that it's a glandular tissue. From the gross anatomy, we say it has 5 lobes: anterior lobe, median lobe, posterior lobe, then 2 lateral lobes. The anterior lobe is devoid of glandular tissue, meaning there are no glands in the anterior lobe. The median lobe bulges into the bladder, and it creates what we call the uvular vesicle. Right. So you have an uvular vesicle. Then that also warrants to say that if your anterior lobe is devoid of glandular tissue, you expect to have no benign hyperplasia in your anterior lobe, right? So if your anterior lobe does not have glandular tissue, you don't expect to have benign prostatic hyperplasia in your anterior lobe because there are no glands there, right? Then if the median lobe is affected, it can actually bulge into the bladder, creating that uvular vesicle, right? Then other things about the prostate: blood supply for the prostate is midrectal and inferior vesical arteries, which is the same blood supply for the seminal vesicles, that midrectal artery and inferior vesical artery. Right? They're also going to be the same blood supplies for the prostate. Right? They are also the same blood supply for the seminal vesicle. Right? Right. Then what really divides the prostate into those distinguished lobes is the presence of the urethra as well as the ejaculatory duct. Right. Then we say the prostate rests on the urogenital diaphragm. Right. And I've told you urogenital diaphragm is made up of sphincter urethrae and deep transverse perineal. Sphincter urethra is what we call external urethral sphincter. External urethral sphincter is one of the sphincters for the bladder, which is actually voluntary because it's skeletal muscle. Right? Then histologically, the prostate is made up of 30 to 50 tubuloacinar glands. Then you need to remember that it has 3 zones. Then you also need to know that of those zones, you have peripheral zone, central zone, and a transitional zone. Cancers are common in the peripheral zone. Right. So we say PC to remember. Right. Then I think this is now showing us the vas deferens, the duct joining the duct of the seminal vesicle. Then you create ejaculatory duct there. Right. And this is what I'm saying: on the posterior surface of the bladder, the 2 vas deferens will separate the two seminal vesicles on either side. And also remember that the ureter crosses the vas deferens in males. In females, we talk about water under the bridge where it is crossed by the uterine artery. Then scrotum, I won't dwell much on it, but it has the same layers as the anterior abdominal wall. Right. Testes, that's more of the histology, where you say that you divide your testes into about 250 pyramidal shaped compartments, and each compartment will have about 1 to 3 lobules, and those lobules will have seminiferous tubules, blah 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 blah. Right. Then the penis, you need to remember that it's a mass of erectile tissue where you have three. We start with the root where there are three. There's the bulb at the center, then you have the two crura. Then they continue as corpus spongiosum, and then you have two corpora cavernosa. Then it is the corpus spongiosum that then dilates to form the glans penis distally, meaning to say your corpora cavernosa do not form any part of the glands, right? And the part of the urethra that we have in the penile is the penile urethra rather, which is lined by pseudostratified columina and stratified columnar epithelium. Within the urogenital diaphragm, we have the membranous urethra, which is also lined by the same epithelium as aforementioned, which is stratified and pseudostratified columnar. But the distal end of the penile, there is stratified squamous. Right? Then prostatic urethra, the one in the urethra, has transitional epithelium. Right? Then the terminal end of the penile urethra, you need to know that it dilates to form the navicular fossa, which I think this picture here is trying to show. Yeah. And then the meatus there, the external urethral meatus then becomes the narrowest part of the urethra. And then you also need to know which one is the least dilatable, which is your membranous urethra, which one is the widest and most dilatable, which is your prostatic urethra. Right? Females, we need to know the uterus, how you can divide the uterus into a fundus, a body, and a cervix. Cervix is divided into, histologically, we talk of an endo and an ectocervix, but in gross we really want to say supravaginal and vaginal cervix. Right. Then blood supply for the fundus is ovarian artery coming from the aorta, meaning the lymphatic drainage will go to para-aortic nodes. Right. Then some of the lymph from the uterus also goes to internal and external iliac nodes, though there is no blood supply from external iliac artery. Then the lymph that is at that point there where the uterine tube, the intramural part, joins the uterus, there is attachment of the round ligament of the uterus there, which you remember from your abdomen. It travels within the inguinal canal to attach to the labia majors. So lymph from that point will actually follow the round ligament of the uterus to the perineum, and lymph drainage in the perineum is actually the medial group of superficial horizontal inguinal lymph nodes. Right. Then also remember the uterine tube, how you divide it into infundibulum, where you have the fimbriata, the ampulla, which is the widest and the most dilatable, where fertilization actually occurs if you're unfortunate. Then the isthmus is the narrowest, and isthmus is more like a neck. Then the intramural part is the one that projects into the uterine body. right? Then you also need to know that there's a broad ligament that surrounds it. The broad ligament, there are contents of the broad ligament. You count things in twos. So there are two ligaments, round ligament of the ovary and round ligament of the uterus. There are two arteries, ovarian artery, uterine artery. In the upper margin, there is the uterine tube. Then there are two vestigial remnants, which we call paraoophoron and epiophoron, which are simply representing the degenerated mesonephric ducts in the females, if you go back to the embryology. Right. Then we also have an ovary. Ovary, please remember that there's a lot of ligaments. There is suspensory ligament of the ovary where the blood vessels travel. It suspends the ovary to the lateral pelvic wall. Then there is round ligament of the ovary. It suspends the ovary to the lateral margin of the uterus. Then there is mesovarium, which basically attaches the ovary to the posterior surface of the broad ligament, meaning to say that the ovary is behind your broad ligament. Then we talk of ovarian fossa. The ovarian fossa, superiorly, we have the external iliac vessels. Posteriorly, we have internal iliac vessels plus the ureter. Anteriorly, we have the broad ligament. Inferiorly, we have the obturator vessels and nerves. Right. Then I talked about how you can damage the ureter during hysterectomy. So you may want to remove your uterus, then you want to clamp the uterine artery. But due to the relationship with the ureter, remember the uterine artery actually crosses on top of the ureter. So you may clamp the ureter instead, and that will now result in urine leaking into that peritoneum, and that's going to be very bad, so that they can actually get infections. And worse still, if you don't notice that, then they come back days later with severe sepsis. Then imaging, not for your age. Then arterial blood supply for the pelvis. We are concerned with internal iliac. So rejog your memory with abdomen. We have abdominal aorta, ends L4 by dividing into a right common iliac and a left common iliac, and the one at the center, which is the median sacral. The common iliacs will divide at the pelvic brim to give us the external iliac, which we know is going to the lower limb. After the inguinal ligament, it will change name to become femoral. Then we have internal iliac, which will divide into an anterior division and a posterior division. I think this diagram is trying to do justice with it. So you need to know which branches are from the anterior, which branches are from the posterior. In general, all the branches fall under the mnemonic. I love going places in my very own underwear. That's what you use to remember. The first three, which is iliolumbar, lateral sacral, and superior gluteal, they come from the posterior division. The rest will come from the anterior division. The veins will follow the artery, so I won't go waste time on the veins of the pelvis. Uterus, the blood supply is uterine artery, plus remember I said the fundus also gets blood supply from the ovarian artery. Ovary behaves like the testis, behaves like the suprarenal glands in terms of the venous drainage, meaning the veins on the right, they drain straight into the inferior vena cava. Those on the left, they first go to left renal vein. Then from left renal vein, they go to the IVC. Okay. Then for vagina, all you need to know are the supports of the upper third, middle third, lower third. Then you talk about lymph for the upper third, middle third, lower third. So supports for the upper third is the pelvic diaphragm. Supports for the middle third, it's urogenital diaphragm. Supports for the lower third, it's perineal body, right? That lymph drainage, lymph for the upper third, it's external iliac and internal iliac. Lymph for the middle third, it's internal iliac. limb for the lower third is the one for the perineum, which is the medial group of superficial horizontal inguinal lymph nodes. Right, great. Then it's 8 centimeters. There's a perineal part and a pelvic part. That's why you're going to see an opening in the pelvic diaphragm. Nothing fancy about it. There are no glands. It's lined by stratified squamous. Embryologically, it comes from the paramesonephric duct as well as your urogenital sinus. Right. I won't talk about these things. No. Then we have the sacral plexus. Sacral plexus is really behind your rectum, but in front of the piriformis muscle. I've already told you some relations of the rectum there. Meaning behind the rectum, there's sacral plexus, there's piriformis, there's the sacrum and the coccyx. Eh? So it's made of L4, L5, then S1 to S4. S5 and the coccygeal nerves and part of S4, they create another plexus, which we don't really learn, which is the coccygeal plexus. So I will not include it for the purpose of this video. We'll talk about L4 to S4. L4, L5, when we did abdomen, it's what we called the lumbosacral trunk. So lumbosacral trunk is going to emerge on the medial surface of the psoas major. It comes to join your sacral nerves to create the sacral plexus, which will give me nerves that are unique to the lower limb, as well as some that are unique to the pelvis, which brings about things exiting the greater sciatic foramen. I hope this makes sense. Then you also have things entering the perineum via the lesser sciatic foramen. And the mnemonic for things entering the lesser sciatic foramen, it's pinned. So there is the pudendal nerve. The I, it's the internal pudendal vessels. The N, it's the nerve to the obturator internus. Then the T is the tendon of that muscle, which is obturator internus. Right. The nerve supply for pelvic organs is basically inferior hypogastric plexus. It carries both sympathetic and parasympathetic. Right. Then this is the surface anatomy in the perineum, where you divide your triangles into a urogenital triangle anteriorly, then an anal triangle posteriorly, there where there's the opening of the anal canal. That's where you also then describe the ischial erectile fossa on either side. Then in the urogenital triangle, that's where we're aimed at describing the scrotum, right? For anal canal, you need to be able to distinguish its upper third from its lower third, right? Then that's for the female. You need to be able to know like what fuses to form the fourchette, and then go and fuse to form the mons pubis, which basically is the labium minus, right? Then the last thing will now be to understand contents of the pouches. Right? So how you remember your deep perineal pouch is the glands in the male, which are your bulbourethral glands. Right? The glands in the female, which are your greater vestibular glands, they are in the superficial perineal pouch. But the ducts of the glands of the male are in the superficial. They open in the what do we call this? Penile urethra. Right. Then also remember, find a way to remember the rest of the contents. For example, membranous urethra is in the deep perineal pouch. Penile urethra is in the superficial. For females, you say part of the urethra, part of the urethra. Right. Then also, the muscles that make up your urogenital diaphragm, they're in the deep perineal pouch. And one of them is sphincter urethra, the other one is deep transverse perineal. So if deep transverse perineal is in the deep perineal pouch, there should be a muscle called superficial transverse perineal in the superficial perineal pouch. Right. Then the root of the penis and the clitoris is also a content of your superficial perineal pouch. Right. So if you can find a way to know all these things, you'll be good.